If you're here for the Management of Bipolar Disorders with a focus on Pharmacogenetics webinar, then you are in the right place. Today we have two of Genomind's medical science liaisons, Dr. Gabriela Williams and Dr. Tori Hoffman, both PharmDs. So they'll be your presenters this evening. It'll be about a 45-minute presentation, and then we'll try to leave 15 minutes at the end for Q&A. Speaking of Q&A, if you just joined us, I want to orient you to the bottom of your screen where you'll see a Q&A box at the bottom. So if you need to ask questions, ask those questions via the Q&A box. During the presentation, you'll have the Genomind Medical Affairs team in the background trying to answer questions. Whatever we don't think we can answer via text message here, we will answer at the end in a live Q&A session. So let's introduce our speakers tonight. So first we have Dr. Gabriela Williams, pharmacist, PharmD. So Dr. Williams is, like I said, a medical science liaison here with Genomind. She works out of Indianapolis and covers the Midwest region. She received her PharmD from Purdue, where she also minored in psychology. So Dr. Williams completed her PGY1 pharmacy residency at Northwestern Memorial Hospital in Chicago and her PGY2 pharmacy residency with Eskenazi Health in Purdue in Indianapolis. So Gabby is board certified. She's a board certified pharmacotherapy specialist and also board certified psychiatric pharmacist, so dual certifications. Her clinical background is highlighted by extensive work in the acute care management of individuals with SMI or serious mental illness. We will be sending out this recording tomorrow. We'll be sending out the slides as well, so you can see the links there for some of Dr. Williams' presentations. So in addition to Dr. Gabby Williams, we have Dr. Tory Hoffman, another pharmacist. So Tori is currently our medical science liaison on the West Coast in sunny San Diego. So she received her PharmD from Albany College of Pharmacy, and she's still licensed in the state of New York. I imagine California as well. Prior to coming to Genomind, Dr. Hoffman held the position as supervising pharmacist at an independent pharmacy where she managed clinical operations, and she implemented one of the first pharmacogenetics programs with a family practice provider group near her house and or near her pharmacy. And that's what led her to us. In addition to that, Tori manages, she's sort of the clinical face of our Genomind 360 platform. So all the educational components that we produce at Genomind goes through Tori's hands before you see them. So those are our speakers tonight. And by the way, I'm Dan Dowd. I'm the VP of Medical Affairs here at Genomind. If you have any questions that we cannot answer during this presentation, feel free to email the team at medicalaffairs@genomind.com. So that's enough for me, and now I'm going to hand it off to our first speaker, Gabriela Williams.
Thanks so much for that intro, and thank you to everyone who's joining us tonight from home for our discussion. So as a quick roadmap of what we'll be discussing tonight, we'll do a nice quick overview of bipolar disorder and some general treatment principles, as well as guideline recommendations. And then we'll dive a little bit deeper into the role that pharmacodynamic and pharmacokinetic genes may have in our treatment decision-making process for our patients with bipolar disorder. Now, last but not least, we'll use GenMed Pro, our gene-drug interaction software, to help guide us through a sample patient case. And we'll talk about how we can leverage that tool in medication management for our patients. Let's go ahead and dive a little bit deeper into bipolar disorder and the general treatment principles of this disease state. Bipolar disorder has been estimated to affect approximately 7 million individuals within the United States. And if we specifically look at data from the National Comorbidity Survey replication, which can be seen by this bar graph over to the right of the screen, this accounts for approximately 2.8% of the United States adult population. Now, when we're looking a little bit more specifically at bipolar 1 versus bipolar 2 disorder, it's been estimated that the lifetime prevalence of bipolar 1 disorder is approximately 0.6 to 1%, and that of bipolar 2 to be about 0.4 to 1.1%. Now, in general, we see an overall equivalent frequency of bipolar disorder in males versus females, and an overall age of onset of about 25 years of age. Now, I want to direct everyone's attention to the graphic over on the left hand of the screen, which identifies the 12-month prevalence of common mental illnesses within the United States population. And when we look at this graphic, we can see that bipolar disorder isn't particularly the most prevalent mental illness that we see in the United States. But it should be of note that within adults with bipolar disorder within the past year, approximately 83% of individuals were classified as having a serious degree of impairment based on Sheehan Disability Scale scores. And this particular degree of serious impairment was considered to be the highest percentage among all mood disorders within the United States. And I think this is a really important factor for us to consider, and it really highlights the significant impact that this particular disease state can have on patient lives. Now, to dive a little bit deeper on the evaluation and the diagnosis of bipolar disorder, there's going to be some key considerations that we use to differentiate the different types of this disease state. Now, most significantly, the presence of a manic episode is required for the diagnosis of bipolar 1 disorder. Now, in addition to that manic episode, hypomanic or major depressive episodes can precede or follow that mania, but are not particularly required for the diagnosis of bipolar 1. Now, this will be a little bit more of a consideration in something like a bipolar 2 disorder, in which patients do not have a history of mania. But bipolar 2 is going to be more defined by the presence of current or past hypomanic and major depressive episodes. Now, last but not least, cyclothymic disorder will be defined by numerous periods of hypomanic and depressive symptoms that don't quite meet that criteria for hypomanic or major depressive episodes. And symptoms within the course of this particular disease state must be present for at least 2 years. Now, furthermore, numerous diagnosis specifiers such as mixed features, psychotic features, rapid cycling, etc., can be used to further identify key patient-specific factors within a particular disease course. Now, as I'm sure many clinicians on tonight's call can attest to, the diagnosis and the evaluation of bipolar disorder isn't quite as black and white as these diagnostic criteria may seem. And actually, approximately 69% of individuals with bipolar disorder are initially misdiagnosed. Now, there's a lot of contributing factors that can lend themselves to misdiagnosis. Mania, for example, can be a very distinct clinical feature, but some of the other symptoms identified in bipolar disorder can look very similar across other disease states. For example, depressive symptoms can look the same within a major depressive disorder and a bipolar disorder. Now, furthermore, patients may lack insights into certain manic symptoms or hypomanic symptoms, and this may lead to a lack of reporting of those symptoms to a clinician. And in final addition, approximately 70% of individuals with bipolar disorder also have comorbid conditions. That can be anything from anxiety to substance use disorders. And these comorbidities can further cloud that picture and cloud that evaluation. So really, truly, the first step is going to be a thorough patient evaluation and a good assessment of current and past symptoms, as well as the course of illness, family history, and any previous treatments and responses. And this really is a key factor in the first step of approaching and managing bipolar disorder within a patient population. Now, in addition to the diagnosis of bipolar disorder not always being as clear and as black and white as we would like it to be, the management of this disease state can further add on an additional layer of complexity. So up on the screen right now, we're looking at the acute management treatment guidelines for manic and depressive episodes within bipolar disorder, as identified by the Canadian Network for Mood and Anxiety Treatments, or CANMAT. And these first-line and second-line treatment recommendations come directly from their 2018 guidelines for the management of patients with bipolar disorder. Now, I won't speak more specifically to each and every single individual medications that's listed within this particular table, but as an overall summary, we see consistently recommended within these guidelines the classic mood stabilizer medications, things such as lithium, divalproex, carbamazepine, and lamotrigine. And in addition to these classic mood stabilizers, we also see a number of second-generation antipsychotic medications, either recommended as monotherapy or in conjunction with those mood stabilizer medications. Now, another key consideration to point out and to highlight here within these guidelines is that we do see various treatments and differing treatments recommended for acute mania versus what we see recommended for acute depression, both in bipolar 1 and in bipolar 2 disorder. So it's really necessary to approach the management of patients depending on what specific episode they may be presenting with at any given time. Now, very similarly in this next table here, where we see maintenance treatments in bipolar disorder, again, we'll see those first-line and second-line treatment options as recommended for the maintenance of both bipolar 1 and bipolar 2 disorder. And again, we're seeing those same mood stabilizer medications, as well as those second-generation antipsychotics, both recommended as monotherapies or in conjunction with those mood stabilizer medications. Now, one of the biggest aspects that I really wanted to highlight when we look at these treatment guidelines from HandMatch is that we have a number of medication options available to us when we're approaching the treatment of our patients with bipolar disorder. But those medications can vary vastly in their evidence for their use in specific episodes or in specific types of bipolar disorder. And additionally, we need to be very mindful of the side effect profiles that each one of these individual agents may bring to the table. This full comprehensive evaluation of these various medication options, along with other key patient-specific factors, really need to be assessed as we're approaching that treatment or as we're approaching treatment considerations and recommendations for our patients. Let's go ahead and dive a little bit deeper into the evidence that assesses the use of these various medications, specifically those mood stabilizers or those second-generation antipsychotics in the management of bipolar disorder. So the current study that's presented on the screen here was a study that was conducted by Srivastava and colleagues and really aimed to identify the number needed to treat, number needed to harm, and the likelihood to help or harm of various mood stabilizers and second-generation antipsychotics versus placebo in both acute mania and acute bipolar depression. Now, just as a reference point, the number needed to treat is a consideration of how many patients would need to be treated with one intervention over another intervention to have an additional positive outcome. And the very similar type of consideration would be for number needed to harm, except that outcome would be one that we would like to avoid or a harm. In general, when we look at the literature base as it relates to psychiatric disease state management, usually a number needed to treat of less than 10 is considered to be appropriate, and a number needed to harm of greater than or equal to 10 is often considered to be appropriate. In general, of course, this will vary based on the clinical importance or clinical significance of some of these adverse events. But I would say in general, we're usually looking at a low number needed to treat and a high number needed to harm. Now, furthermore, that likelihood to help or harm will be a ratio of that number needed to harm versus that number needed to treat, with numbers greater than 1 indicating a higher likelihood to help, and numbers less than 1 often indicating a higher likelihood of an agent or treatment modality to harm that patient. So when we take a look specifically at the numbers of the studies here and focus more specifically on that acute mania data, we're seeing fairly acceptable numbers needed to treat across the various mood stabilizers and across the various second-generation antipsychotics, with numbers needed to treat ranging anywhere from 4 to about 8 for these various agents. However, when we look more specifically at those numbers needed to harm, and secondarily as well, that likelihood to help or harm, we're going to see more of a differential of these agents, particularly in their propensity to cause sedation, as was identified within these acute mania trials. So these particular agents can range anywhere from a number needed to harm of about 5 that we see with some of those second-generation antipsychotics, upwards to about 27 that we see with that classic mood stabilizer lithium. So again, we see this differential in the likelihood of these medications to cause side effects or cause adverse events for patients. Now, conversely, when we look at that data on acute bipolar depression management, we look at that number needed to treat, we're seeing a little bit more of a differential there with the number needed to treat of about 4 for the olanzapine and fluoxetine combination product, upwards to about 15 for a number needed to treat for lithium in a bipolar depression. However, more significantly here, if we focus our attention to those numbers needed to harm that were assessed for both weight gain and sedation in these particular studies, we're seeing a much more considerable difference here between our various treatment modalities as they were assessed versus placebo. And specifically, when we look at some of those second-generation antipsychotics, we're seeing numbers needed to harm of about 6 to 7, up to 12 potentially, for things like weight gain and sedation that we can see with these medication options. Now, based on all of these results and based on this data, the authors concluded that Overall, clinicians have a number of medication options that have been supported by superior efficacy compared to placebo in clinical trials. But it's not just that efficacy piece that we need to be mindful of. We have effective treatment options available to us, but we also really need to be mindful of tolerability concerns. And it's this assessment of both efficacy and tolerability that's necessary to crucially inform our optimal treatment choices for our patients. Now, furthermore, a somewhat similar analysis of number needed to treat and harm was conducted by Deary and colleagues, but this particular assessment looked specifically at those second-generation antipsychotics in bipolar disorder and assessed approximately 2,200 patients with depressive episodes and approximately 6,000 patients with manic or mixed episodes. And these studies looked at these second-generation antipsychotics versus placebo, as well as versus those established treatments. Most notably are classic mood stabilizers like lithium, divalproex, and lamotrigine, as well as the first-generation antipsychotic haloperidol. Now, again, when we're looking at these numbers needed to treat across these study assessments, we're seeing fairly acceptable numbers needed to treat, anywhere from about 5 to 6, as seen in acute depression studies, to about 4 to 5 within the mania and mixed literature, and then a number needed to treat of about 4 to prevent a relapse to either depression or to mania within this particular meta-analysis. Now, when we look at those numbers needed to harm, we're seeing a little bit of a differential. When we look at those depression studies that utilized medications like olanzapine and quetiapine, we saw a lower number needed to harm, a number needed to harm of about 12 for adverse event withdrawals. But when we look at those mania and mixed episode studies and also those maintenance studies, that number needed to harm was considered to be about 24 for any, or 22 to 24 for any adverse event withdrawals. And furthermore, the study authors identified that these medications, the second generation antipsychotics, showed similar efficacy versus those established treatment options in bipolar disorder, but were associated with overall fewer withdrawals for adverse events. Now, while that all sounds wonderful, it's still worth noting that study authors identified that when we specifically look at those second generation antipsychotics versus placebo, we saw higher amounts of weight gain, higher amounts of sedation, and also a higher propensity for extrapyramidal symptoms. And furthermore, even though we did see fewer withdrawals for adverse events versus those established treatments, we still saw higher amounts of weight gain and higher amounts of sedation with these second generation antipsychotics. So again, very similar to the previous study conducted by Srivastava and colleagues, Deary and colleagues came to the conclusion that we have a number of medications that are available to us that have shown efficacy versus placebo and also seem to be as effective as these established treatments conventionally used in the management of bipolar disorder. But there's still that piece that we need to be very mindful of tolerability concerns and side effect profiles with these second generation antipsychotics, most notably being considerate of the weight gain that we can see with these medications, as well as the sedation that we can see with these medications. So with all of this guidance and all of this evidence for the use of various mood stabilizers and antipsychotic medications in the course of bipolar disease management, what does that actually end up meaning for our patients? If we look at data from the Systematic Treatment Enhancement Program for Bipolar Disorder, or the STEP-BD trial, it was approximated that 58% of individuals were able to achieve recovery within that trial. But approximately 48% of individuals experienced a recurrence of symptoms during the 2-year follow-up period of that trial. And authors concluded based off of this data that these results demonstrate that mood episodes in bipolar disorder are prevalent and are likely to occur within the patient population. Now, the risk factors and the reasons for recurrence can be quite varied, and they can be very patient-specific. But the literature has guided us to some specific risk factors for recurrence within bipolar disorder. And that can include anything from residual symptoms after initial recovery, to psychiatric comorbidity and substance use disorders, to the number of previous episodes, as well as stressful life events, and then specifically to medication non-adherence as well. And to specifically put that focus on medication, since that is the overall focus of our discussion here tonight, it's really been approximated that half of individuals with bipolar disorder were found to be non-adherent to medications over a year-long period. And again, the contributing factors to this medication non-adherence can be quite varied, and it can include anything from the complexity of medication regimens to patients' attitudes or insights to medications, to the specific disease course or course of illness, to comorbid conditions or substance use, and also to a lack of a therapeutic alliance with that treatment team. But most importantly, as a key contributing factor that we need to be mindful of here are the adverse effects that can be associated with the medications that we're using as we manage bipolar disorder. And I think this brings in, again, that critical piece of information that we learned from some of the data presented just earlier, that as much as these medications have support for their effectiveness in the management of patients with bipolar disorder, we still need to be quite mindful of the side effect profile and the individual risks that are to be considered with each of these various medications recommended by treatment guidelines. So this particular emphasis on evaluating medications and also the benefits and the risk of medication options brings us directly to our discussion on pharmacogenetics. By definition, pharmacogenetics is the field of research that studies how a person's genes may affect how he or she responds to or tolerates various medications. And it really lays the foundation for how our genetic makeup can underlie medication choices and outcomes. And overall, pharmacogenomics really encapsulates this idea that medication is not a one-size-fits-all process, that various patients will have differing responses as well as differing tolerability to numerous medication options. Now, before we go any deeper into our discussion of pharmacogenetic testing, I wanted to discuss some key considerations and key golden rules of using pharmacogenetic testing in our treatment decision-making process. So first and foremost, PGX testing is meant to be another tool within the clinician toolkit. It's meant to be probabilistic and is not deterministic. It cannot identify the perfect or the best drug or medication for any given patient, and it cannot eliminate all risk of medication either. Like any other tool in medicine, it's meant to provide us with a better estimate of risk or of response to medication. Now, in addition to this, pharmacogenetic testing is meant to be a piece of that clinical puzzle, and it's meant to supplement a good evaluation and good clinical judgment. And information from pharmacogenetic testing should never be the sole source of medication-related decisions. Now, last but not least, the current state of pharmacogenetics or pharmacogenetics as a field is still better at assessing drug tolerability risk. But I will say that this is a rapidly advancing field, and I feel like we have new publications, new data, new guidelines constantly being published that further lends itself to our understanding of how we can use this information within clinical practice. So let's go ahead and take a look at how we can utilize pharmacogenetic-based information in the care of our patients with bipolar disorder by first talking about some key pharmacodynamic genes. Now, at the start of the presentation, I highlighted the role and support for multiple mood stabilizers as well as multiple second-generation antipsychotics. But particularly, we also took a look and highlighted that data and the importance in considering the side effect profile of these various medications. And particularly, we highlighted that consideration for weight gain that we can see with those second-generation antipsychotics. So with this being said, the first two pharmacodynamic genes we'll be discussing tonight will be those that have been associated with antipsychotic-induced weight gain. And the first of these genes will be MC4R, or the gene that encodes for the melanocortin-4 receptor. And this particular gene and the associated receptor has been thought to play an integral role in regulating food intake and satiety signaling that happens between brain and body. Now, what we're looking for in this particular gene is the presence of two risk alleles, or that AA genotype, as this AA genotype has been shown to influence the risk of weight gain that we can see with those second-generation antipsychotics. Now, the data to support this association comes from several different studies. The first study being conducted by Malhotra and colleagues, where study authors conducted a genome-wide association study of second-generation induced weight gain in patients exposed to second-generation antipsychotics. And they further confirmed their results and confirmed their findings in 3 independent patient cohorts. And so if we look to this bar graph to the right of the screen here, which identified that antipsychotic-induced weight gain in approximately 350 patients treated with numerous antipsychotic medications, we can see fairly consistently that green bar that represents the AA genotype being associated with a greater change in weight in these various patient cohorts. In general, across all of the patient cohorts here, we're seeing that those with the AA genotype gained approximately 2 times the amount of weight compared to those with the CC or the AC genotype, lending itself consistently across these patient cohorts to an increased risk of weight gain that we can see with this AA genotype. Now, these results by Malhotra and colleagues were corroborated by a study that was conducted by Zhang and colleagues. And Zhang and colleagues not only looked at antipsychotic-induced weight gain, but they also looked at the influence of MC4R genotypes on various other metabolic measures. So if we look particularly at the bar graph over to the left of the screen here, we can see the antipsychotic-induced weight gain data in approximately 560 antipsychotic naive patients. When we look at the graph down at the bottom that represents those patients with the AA genotype, we can see that approximately 40% of individuals with this AA genotype gained greater than 7% of their body weight. Now, this is going to be in comparison to about 20% of those individuals with the CC or the AC genotype gaining that greater than 7% weight gain that we can see in this particular patient population. Now, in addition to this increased risk of weight gain that we saw in this patient population, the study authors also assessed these various other metabolic measures, including waist circumference changes, glucose changes, and a number of changes to lipid levels as well. And what we can see in the overall patient cohort of approximately 2,000 patients was a statistically significant difference in waist circumference changes, as well as HDL level changes, particularly of note within those in the AA genotype. And when we particularly are looking at those antipsychotic and antipsychotic naive patients in the patient population, we saw a statistically significant difference in triglyceride levels. Again, an increase in that triglyceride level in those with the AA genotype. So this data taken together, the data by Malhotra and colleagues and the data by Zhang and colleagues, really indicates that increased risk of weight gain, as well as that increased risk of key metabolic changes that we can see with this AA genotype. And that can really help us. This information and taking this into consideration can really help us when we're identifying that risk to benefit ratio of these second generation antipsychotics as a class, or amongst the various second generation antipsychotics and their inherent propensity to cause weight gain or to cause these metabolic side effects. Now, in addition to that MC4R gene, the 5-HT2C gene, which encodes for the serotonin 2C receptor, has also been implicated in satiety signaling as well as appetite regulation. Now, in this particular gene here, we see that approximately 80% of the general population carries the CC genotype. And that CC genotype is what we would consider to be associated with the standard weight gain risk that we see with the second generation antipsychotics. Particularly in this gene, what we look for is that T allele, as that T allele has been shown in studies to be associated with a reduced risk of antipsychotic-induced weight gain. And the data for this particular association comes from a study that was conducted by Chen and colleagues just recently in 2020. And the forest plot over to the right of the screen identifies the results from this particular meta-analysis. Study authors looked at this risk of antipsychotic-induced weight gain and the emphasis of that 5-HT2C genotype there within a Caucasian patient population, within an Asian patient population, and also in an overall patient population, which encapsulated over 17 studies that included 3,000 patients treated with these second-generation antipsychotics. And consistently amongst these populations, and within that overall patient population that was assessed, we saw that patients that carried that T allele were about 70% less likely to experience that greater than 7% weight gain associated with those second generation antipsychotics. Again, lending itself to that T allele being associated with that reduced risk of weight gain that we can see with these second generation antipsychotics. So in total, when we utilize this information provided to us by the MC4R genotype, as well as this 5-HT2C gene, we may be able to better assess tolerability risks with these second generation antipsychotics. And by doing so, we can make a much more well-informed decision about the use of these medications or about the use of specific medications within the management of each of our individual patients with bipolar disorder. So with that being said, I'd like to now turn it over to Dr. Tori Hoffman, who will continue our discussion on the pharmacodynamic and kinetic considerations in the management of bipolar disorder, and who will also walk us through our patient case through GenMedPro. Tori, to you.
Great, thank you, Dr. Williams. So we're going to start off here with the human leukocyte antigen, or HLA genetic variation. So the HLA genes are an essential part of the immune system. HLA-A and HLA-B Both encode cell surface proteins that present intracellular antigens to the immune system. Certain genetic variants in HLA-A and HLA-B can actually greatly increase an individual's risk of developing drug-induced skin reactions, including Stevens-Johnson syndrome and toxic epidermal necrolysis, which are both commonly abbreviated as SJS and 10, as well as other life-threatening skin reactions. So HLA-A star 3101 and HLA-B star 1502 have been implicated in the development of life-threatening skin reactions with various aromatic anticonvulsants. The HLA-A star 3101 variant is associated with an increased risk of multiple types of severe skin reactions with carbamazepine. The HLA-B variant star 1502 is associated with an increased risk with carbamazepine, as well as with oxcarbazepine, phenytoin, and phosphenitoin. It's also important to note that with the star 1502, based on clinical data or similar structure, lamotrigine, phenobarbital, and eslicarbazepine may also be associated with increased risk of skin reactions in patients with this genotype. So to add some more context to the increased risk of developing serious skin reactions with certain HLA variants, the first table here identifies the background rates of severe cutaneous adverse reactions, such as SJS or 10. This data comes from the FDA labels themselves of carbamazepine and lamotrigine. As you can see, the presence of the HLA-A star 3101 allele increases the risk of carbamazepine-induced serious skin reactions by almost tenfold, while the presence of the HLA-B star 1502 allele increases the risk more than 100-fold for carbamazepine, 26.4-fold for oxcarbazepine, and 2.4-fold for lamotrigine. If you look now at the second table, here you will find the HLA-B and HLA-A allele frequencies by biogeographical group. As shown in green here, the star 1502 allele, which again increases the carbamazepine-induced skin reactions risk by more than 100-fold, is most commonly found in people of Asian ancestry or Asian populations. So because of the significantly increased risk of these serious skin reactions with the HLA-B star 1502 variant, the FDA label for carbamazepine states that patients with ancestry in genetically at-risk populations should be screened for the presence of HLA-B star 1502 prior to initiating treatment with carbamazepine. Patients testing positive for the allele should not be treated with carbamazepine unless the benefit clearly outweighs the risk. In addition, CPIC, or the Clinical Pharmacogenetics Implementation Consortium, has published guidelines as well. And these guidelines for carbamazepine similarly recommend that if a patient tests positive and that they are carbamazepine naive, not to use carbamazepine in that patient. Now, on our next slide here, we'll find that oxcarbazepine carries very similar warnings from both the FDA and CPIC, which you will find on this slide here. So now let's switch gears a little bit and talk about the role of pharmacokinetic genes in bipolar disorder treatment. So pharmacokinetic, or PK genes, can affect drug absorption, distribution, and or metabolism. So as you can see on this slide, we have quite a few different types of pharmacokinetic genes on our report, 9 to be exact. So let's start with the ones you're probably the most familiar with, which relate to drug metabolism. So drug metabolism is commonly broken down into 2 phases, phase 1 and phase 2. The cytochrome P450 enzymes, or the CYP450s, are largely responsible for phase 1 metabolism. And you can kind of summarize their purpose as making drugs more water soluble so that they can be excreted better. And although there are dozens of cytochrome P450 enzymes, it's been estimated that 6 of them metabolize almost 90% of prescription drugs. So Genomind Professional PGX includes these 6 enzymes, which you see right here, as well as UGT1A4, UGT2B15, and Abcb1. So variability in these metabolism enzymes can influence a patient's response to commonly prescribed medications. These UGT variants are similar to the CYP450s in that they are also responsible for metabolism of certain drugs. So if we look at this visual here, the metabolic effects on medication blood levels, you will find medication concentration on the y-axis and of course time on the x-axis. In this concentration over time curve for different rates of metabolism. So think of that area under the curve representing total drug exposure, which accounts for peak concentration and the rate of degradation. So patients are typically reported as extensive or normal metabolizers, intermediate metabolizers, poor metabolizers, rapid or ultra rapid. So those fast metabolizers are at risk of hypermetabolism of medications, reduced blood levels, which may require a higher dose in order to achieve therapeutic efficacy. On the other hand, those intermediate and poor metabolizers are at a risk of slower drug metabolism, increased blood levels, and may require a reduced dose of medication in order to decrease the risk for side effects. So now that Abcb1 gene stands for ATP binding cassette subfamily B member 1, Abcb1, and it's a rather unique pharmacokinetic gene. So Abcb1 encodes P-glycoprotein or PGP, which is a drug efflux pump, which removes chemicals from inside of the cells. And certain variants in Abcb1 can affect the drug absorption and blood-brain barrier penetration of select psychotropic medications. For example, C3435T variation has been associated with lower PGP function and may predispose an individual to greater drug exposure within the CNS to certain antipsychotics. So for our conversation today, we're going to discuss how this variant can impact aripiprazole, clozapine, olanzapine, and risperidone. So as Dr. Williams discussed earlier in the presentation, the pharmacodynamic genes MC4R and 5-HT2C have been implicated in antipsychotic-induced weight gain. In addition to those pharmacodynamic markers, it has been hypothesized that functional polymorphisms in the Abcb1 gene may also influence antipsychotic-induced weight gain, as these individuals are expected to have higher brain concentrations. So as we can see here in Table 1, Kuzman and colleagues found that in a subgroup of 47 female schizophrenic patients treated with risperidone for 4 months, that there was an overrepresentation of the T allele in the greater than 7% weight gain group, suggesting a pharmacokinetic effect of the Abcb1 variant on risperidone-induced weight gain. So if the Abcb1 variant influences antipsychotic brain concentrations and side effects, then could it impact antipsychotic response? So as shown in Table 2, Bahayan and colleagues investigated the influence of various Abcb1 polymorphisms on antipsychotic response and dosing strategies in schizophrenic patients from a South Indian population. And out of the 243 patients that were initially recruited for the study, 192 completed the 1-year follow-up assessment and selection criteria. Clinical improvement in the study was assessed by percent change scores between initial baseline brief psychiatric rating scale scoring and the score after 1-year follow-up. Patients with improvement of 50% or more in their BPRS ratings after 1 year were classified as responders. So it was observed that the C allele carriers were significantly more likely to respond with an odds ratio of 1.728 and a p-value equaling 0.03. The CC phenotype specifically was associated with response with a p-value of 0.01. And these individuals were able to tolerate higher doses of antipsychotics, which resulted in a better odds of response. So now that we've reviewed the metabolism variants with the CYP450s, the UGTs, and the pharmacokinetic variants with Abcb1, here we have a bit of a summary page. So you can see the different pharmacokinetic considerations for the various second-generation antipsychotics. So those that are bolded on this page are those that are included in the CANMAT guidelines that Dr. Williams discussed. The RX symbol indicates where there are FDA label dosing instructions or specific adjustments based on genotype for these agents. And the notepad icon that you see next to risperidone actually reflects other guidelines. For example, these notepads might reflect CPIC or Dutch Pharmacogenetic Working Group recommendations for genotype-based dosing. So let's take Abilify, for example, or aripiprazole. And if you look on the right here, we actually have the image that you'll find on the first page of the package insert of the drug. So this includes administering half of the usual dose for known CYP2D6 poor metabolizers. So just how common is it to be a poor metabolizer of 2D6 or to have a fast or intermediate metabolism? So you'll see in this other visual here, the stacked bar graphs were adapted from the CPIC guidelines for the 2016 tricyclics recommendations and provide a visual representation of some of the latest 2D6 allele frequencies in the general population. So while the majority do fall under the normal metabolizer phenotype, it has been estimated that up to 10% of the population are poor metabolizers. So of course, it's important to recognize that this is an approximate frequency, that these variations differ across ethnicity, and that they are often updated. So we'll keep that in mind, but very good information to have that up to 10% of the population may be affected by that specific recommendation for a commonly prescribed medication like aripiprazole. So next we have the same chart here, but looking at the mood stabilizers. And I really wanted to highlight with these drugs, especially, that how important it is to recognize that we're looking at gene drug and drug-drug interactions, because both of these can have a major influence on the overall drug exposure. So again, you'll see the RX symbols and the notepad symbols, as we talked about. Carbamazepine and oxcarbazepine have FDA warnings as well as CPIC recommendations for the HLA variants. But it's also important to recognize that carbamazepine is a 3A4 and 5 substrate. Lamotrigine, primary metabolism is this UGT1A4 pathway. Topiramate and valproate also are substrates of enzymes that we look at on our report. So one of the big things to consider with these drugs, especially when they're being used in combination, as many of the CANMAT guideline recommendations show, that you could use lithium or valproate in combination with some other agents. We really want to be familiar with these drug-drug interactions as well. So for example, if you look at the recommended dosing for lamotrigine, you'll find what we've included on the slide here is that because valproate is a moderate UGT inhibitor, when it's used in combination with lamotrigine, the clearance of lamotrigine is going to be decreased. So because of this, the FDA label includes specific recommendations for dosing of lamotrigine in patients who are taking valproate, as you can see the dose escalation here on the right. So that's a lot of guidelines to remember. So we decided to build GenMed Pro so that you can easily access this information all in one place. So to wrap up our presentation on bipolar disorder with a focus on pharmacogenetics, we wanted to do a GenMed Pro demonstration. So before we go to that demo, let's consider the following patient case, which I will read out loud.
Hopefully you can see this screen that I'm sharing. Dr. Dowd or Dr. Williams, can you let me know if you can see that okay?
Yep, we got it, Tori.
Okay, awesome. So here we have Jenny Medcheck, who is a 24-year-old, 120-pound or roughly 54-kilogram Chinese female with a history of dysmenorrhea and newly diagnosed bipolar 1 disorder. She recently required inpatient hospitalization for a manic episode with suicidal ideation. She was treated with lithium and the mania resolved during the hospitalization. She was discharged 6 weeks ago, but she is now presenting with severe depressive symptoms. Her current medications include lithium, 600 milligrams twice daily, acetaminophen as needed over the counter, and she has a Mirena IUD. So here I have a demonstration of GenMed Pro. So you'll see you can find this directly from the clinician portal, the same place you would go to view the patient's results, to schedule the complimentary consults that we offer. So here we have Jenny MedCheck, and you'll see our GenMed Pro tool. So her medication list automatically pops up if you included it when you filled out the initial requisition form. And you can always view your history, print out this screen, save your changes. So here we see her genetic profile. So she has significant variation in CYP2D6. We're finding out she's a poor metabolizer. HLA-B star 1502, positive detection, and UGT2B15, intermediate metabolism. So if we're looking at her current medication list, looks like the Mirena and the lithium are not interacting with either of these. There's a slight increase in the acetaminophen levels, potentially may require lower doses. So here you can see we have legends that can help you determine if this may be a low, moderate, or high risk warning. So if you do want to consider alternatives, you can always use this drop down. So if we were looking at her presentation here in this situation, perhaps you were considering adding on something for the depressive symptoms, as she was, again, has a history of bipolar 1 disorder. So as we discussed in those CANMAT guidelines, there are a variety of different, first line options that we could use for this acute bipolar 1 depression. Her already being on lithium, we might want to consider perhaps something like Lamotrigine. So if we type in Lamotrigine, we'll see here that there's going to be a caution icon because this patient has that HLA-B star 1502. And as Dr. Williams discussed, as we discussed before, that the effect sizes with these markers differ with the mood stabilizers. So for example, with Lamotrigine, there's a possible higher risk of drug-induced skin reactions. So that risk is about twofold higher in those who test positive for the risk of Stevens-Johnson syndrome. But when we compare that to agents like carbamazepine, that was more than 100-fold risk higher. There are specific recommendations that say do not initiate carbamazepine. So if you had typed in that option, you could see here the pharmacogenetic guidelines that come from CPIC, that come from the FDA label, and so forth. So as we had discussed in the presentation, for this patient, if they are carbamazepine naive, the recommendations would be not to use it. So depending on your comfort using your clinical judgment, you may feel comfortable using Lamotrigine. Again, it's not necessarily a contraindication, but we would recommend that you would want to monitor this. Or again, depending on your preference, your clinical judgment, you may prefer to opt for an alternative agent here. So for example, something else that we could consider in place of the Lamotrigine and in combination with lithium could be something like Latuda. Here's this example here. So there was a slight, there was really not much of a change here. Almost didn't catch it myself here, that there was a slight increase, potentially low risk between the Latuda and the Mirena. So if we wanted to compare and contrast that with other antipsychotic options, again, we'd always want to look at those guidelines and determine which of these agents, are indicated in these specific situations. But for Jenny MedCheck, she's a 2D6 poor metabolizer. So this is going to have a significant impact on antipsychotics, several antidepressants, if you were considering those agents. So like we had mentioned in the presentation, for a drug like aripiprazole, there is specific dosing adjustments recommended by the FDA. So again, this doesn't mean not to use it, but if you do want to use Abilify here, we would recommend, per the FDA guidelines, administering at least 50% of that usual dose. So again, this GenMed Pro tool will auto-populate these guidelines for you when they're relevant for your patient. So that's going to be just my quick little demonstration here. And the last thing we wanted to leave you off with was just a quote from Dr. Stephen Stahl, that as the field of psychiatry moves towards a biologically based science, and as we learn more about the biological basis of psychiatric illnesses and their associated treatments, pharmacogenomics will continue to be an increasingly important additional tool for providers. I will stop sharing now.
All right, well, thank you, Tori. Thank you, Gabby. So we have about 9 or 10 minutes left for Q&A. So I'll just reiterate what I said earlier. If you look at the bottom of your screen, you'll see a Q&A box down there. Feel free to, you all have been pretty quiet so far, but feel free to add some questions into that Q&A box. And then Dr. Hoffman, Dr. Williams, and myself will do our best to answer them. If you're feeling a little shy asking your questions, then feel free to send us an email at medicalaffairs@genomind.com. So with that said, we'll just sit and wait for those questions to roll in. So I imagine everyone is typing feverishly right now.
Or if anyone has any medications they want us to throw into GenMed Pro, that's always a fun way to burn some time, right?
Yeah, we can do a real live GenMed demo.
Another one.
Okay, so I think we have one question. All right, this is a good one. So the Abcb1 gene, let's do a general explanation of that. What is P-glycoprotein? What does it do? And how does the gene impact P-glycoprotein? What's the significance of that on a drug like Abilify?
Yeah, absolutely. I can pull that slide back up because I do think the visual helps a little bit with the Abcb1. So let me just pull that back up.
Well, while you're doing that, Tori, I'll start a little background information on it and kind of repeating what you said earlier. So, oh, well, it's up. Okay, so
Got it.
You got it. Take it away.
Yeah, so the Abcb1 gene, which again has a big long name for ATP binding cassette protein, one of the ways I kind of like to explain it is almost think of it like a revolving door, something that, if you miss your exit, you're going to get pushed back out. So this Abcb1 encodes this P-glycoprotein or this PGP efflux pump, or you think of it, we say a bouncer at a club that's job is to pick people up and toss them out if they're acting silly. So this pump really can help us regulate the concentrations of certain drugs or other compounds across these target tissues. So you can think of it as kind of this protective pump. So when you have a genetic variation here, it's as if the pump is not doing its job as efficiently. It's not kicking those chemicals back out. So our belief is that patients with this marker can have an increased drug exposure. So we use that term drug exposure to help capture that someone might have an altered metabolism and or a variation in the Abcb1 gene. And we look at two different SNPs or single nucleotide polymorphisms in this gene. And the one that we focused on for this presentation is the SNP that affects the concentrations of certain antipsychotics across that blood-brain barrier. So for example, aripiprazole. On the other slide, I used an example of a study with risperidone that at a given dose, if someone has this genetic variant, they may be having a higher concentration of that drug in the target tissue, which has been associated with an increased risk for side effects. So some of these drugs have been associated with higher metabolic side effects in patients with this marker, for example.
Thanks, Tori. So while you were talking in the background, a bunch more questions rolled in here. One of them that came in has to do with the new, the new kid on the block as far as antipsychotics go. It's not entirely new, it's partially new. It's Lybalvi, which is olanzapine and samidorphan. So I'll take this one because I pulled it up in GenMed Pro in the background.
Yeah.
So does it have a different weight gain profile? The answer is yes, which is kind of entirely the point of Lybalvi. Olanzapine is one of the worst offenders when it comes to weight gain, along with clozapine. Olanzapine is now available as a compound drug with samidorphan, and samidorphan is an opioid antagonist. And because when you can block that reward pathway, that opioid reward pathway, the thinking is that somehow that reduces some of these metabolic issues. So yes, there is less weight gain with Lybalvi. And then as far as the metabolism goes, the metabolism of olanzapine is mostly CYP1A2, which is why smoking has such an impact on olanzapine serum levels. And then when it comes to Samidorphan, I think that's UGT, but let me double check it. Yeah, no, samidorphan is primarily 3A4.
So it
It's
only exists now as Lybalvi. The samidorphan is not available in its own entity yet.
Yep.
So I actually did that evaluation for GenMed Pro, so I happen to be a little familiar with this one. So yeah, you can see right here, we have it in GenMed Pro ready to go.
Thanks, Tori. I forgot you did that one. You're the expert there. I should have just handed it off to you. Okay, so we have a question about MC4R and 5-HT2C and whether or not that can predict weight gain with other medications, for example, Depakote or antidepressants. So, Gabby, you want to take that one?
Yeah, so I have not seen any data of those two genetic variations as they relate to some of these other medications and the weight gain that we can see. Now, inherently, those are still considerations, of course, that we want to have with those medications. We know Depakote is a major offender when it comes to weight gain, lithium as well, but I haven't seen direct associations in the literature, at least to date, of those two genetic variations. Now, I know the second part of that question as well is, can these markers help to predict the ameliorating effects of metformin or of using samidorphan in combination with olanzapine in that combination product? And unfortunately, there's no data to suggest that, but I think that comes into consideration just from a clinical decision-making process. If we have a patient that we know is at a higher risk of this weight gain, number one, we can consider using those medications that are maybe a little bit more weight neutral, weight favorable comparatively of the second generation antipsychotics, or we're having those conversations, right? We're having those conversations about what are some lifestyle changes that we can do, that we can incorporate to potentially offset some of this weight if there is that increased weight gain risk. Or are there some of these pharmacologic management options that we can consider? And that may be a conversation we're just having earlier on, especially if the patient may be at this higher risk. Now, by no means does it mean that everybody who is at a risk or a higher risk based off of these genotypes needs to be on one of these medications, but I think that's something that needs to take into consideration patients' prior treatment, their responses, their tolerability, and just having that general conversation with the patient about that potential weight gain risk.
And just to, the initial point is there is no data relating MC4R and 5-HTC to weight gain with anything other than the second-gen antipsychotics. MC4R itself is associated with weight gain risk independent of any medications. And so, you know, it may just be that these people are more sensitive to weight gain in general, and then the antipsychotics amplify that risk. Okay, a question about the cost of the service and how do we refer patients for the service? Well, if you are a prescriber, you don't need to refer patients. So if you have prescriptive authority, you can order this test right now, today. If you're not a prescriber, we would encourage you to partner with a prescriber to order the test for your patient. You know, the best way to order the test, I would recommend you go to our website, Genomind.com. There's a sort of a new provider section where you can enter your information, and then someone will reach out to you tomorrow or Monday. Or once again, you can email me at medicalaffairs@genomind.com. Tell me where you're located, and I will put you in touch with the appropriate representative in your area. So I think we have time for maybe one or two more questions.
Hey, Dan.
Yeah.
They'd asked about cost. Do you want me to pitch in on that one?
Oh, I'm sorry. Go ahead, Tori. Yep.
Yeah, absolutely. So typically for commercially insured patients, they will usually pay no more than $399. So $399. Certain situations with Medicaid may cost the patient $0. There's some, different differences across the states, and typically the standard Medicare would be $0 copay for the patient. So typically, you could assume your patient with commercial insurance would pay no more than $399, and we do a pay up front type of situation. So, and there's also payment plans over time if needed, things like, I think we use Affirm, right? So if they don't want to, use that all up front, and then with the new year coming up, if they have FSA or HSA, they can apply that for the $399 as well. So I always like to mention that right around that time of the year when people are signing up for their next year's plan.
Thanks, Tori. You kept me honest there. I should have mentioned that there is currently a Medicare pharmacogenetic policy in place. So most Medicare patients will be eligible for this with zero out of pocket. Then I think the last question we have here. So I've used genetic testing, but sometimes they tolerate the med that genetic testing reported they are poor metabolizers. How does this happen? Well, I'm going to go back and reiterate what Dr. Williams said early on. Pharmacogenetics is one piece of the puzzle. If you are depending on pharmacogenetics to answer all your questions about medication selection and outcomes, then you are doing it wrong. So knowing that somebody is a poor metabolizer just tells you what the likelihood of having a higher blood level is, and vice versa. If you're a fast metabolizer, you have a higher likelihood of having lower blood levels. It's a tool to use to personalize dosing. There are very few contraindications in the world of pharmacogenetics. I think there's 5 of them in total. Being a poor metabolizer at something is almost never a contraindication. It's an alert to you as the provider to consider lower doses, generally half of the normal starting dose. So again, this is one piece of the puzzle. Use this with all your other clinical judgment that you've accumulated over the years, and that's the proper way to use it.
One of the other things I want to just throw in for that one too is, here's another value for GenMed Pro, is not all of these drugs go through these pathways in the same amounts. So for example, I'm going to show venlafaxine here, has 4 different pathways it's a substrate of. So if you're a poor metabolizer of venlafaxine, this has a different influence on that total serum level than perhaps something like Celexa or Lexapro, which are primary substrates of that pathway. So this is exactly why we built GenMed Pro, so that you can compare and contrast and see, again, the probability that there might be some clinical significance here. So it's exactly why we built this, and you have access to this tool for every patient that you do, and virtually every drug you can think of will pop right up in here for you.
Thanks, Tori. That pretty much brings us past the top of the hour, so I think we'll wrap things up here. I want to thank the speakers, Dr. Hoffman, Dr. Williams. Everyone who's registered will get a copy of this webinar with the slides, and there'll also be a link to rate your speakers tonight. It's a survey that literally takes 45 seconds, so I'd appreciate if everyone could fill out that survey so we can improve on our programs moving forward. Okay, again, if you have any clinical questions or any questions, medicalaffairs@genomind.com. Thanks for joining us tonight, and have a good night. Thanks.
Good night, everyone.